Okay. Good afternoon and welcome to Grand Rounds here at St. Paul's Hospital. Thank you very much for joining us. Before we start, I'd like to just start with a land acknowledgement. I would like to acknowledge that we live, work, and play on the territories of the Musqueam, Coast Salish, and Tsleil-Waututh Aboriginal nations, and we are very grateful to be here on this land today. Without further ado, I'd like to introduce Dr. Hayley Merkeley from Hematology today, and she's here to give us a fantastic presentation and overview on sickle cell disease in BC. Thank you.
Thanks so much, Chris. Thank you, everyone, for having me. So as Chris mentioned, I'm a hematologist here at St. Paul's. I am the medical director of our red cell disorder program here in British Columbia that serves all our patients with red cell disorders, mainly sickle cell anemia and thalassemia in the province. So today we're going to discuss the rising prevalence of sickle cell disease, review the current treatment landscape, and highlight novel pharmacotherapies with a focus on curative therapies that are actually commercially available now. These are my disclosures. And so before we talk about the current landscape, I'm going to take you far back in time to West Africa about 11,000 years ago. And this was a time when people were switching from hunter-gatherer societies to more agrarian societies. And they started clearing the bush of West Africa to grow yams. And as a result of bushland being cleared, there were increasing pools of stagnant water sitting around. Enter the Anopheles mosquito, which, as you know, carries Plasmodium species. And so it was the selective pressure of malaria around 11,000 years ago that really started to alter red blood cells. And in the case of sickle cell disease, this led to a point mutation in beta globin, which is one of the key components of hemoglobin, that with this point mutation under conditions of hypoxemia, the altered hemoglobin S, will abnormally polymerize and distort the red blood cell into the characteristic sickle shape that you can see here. I don't know if you can see I can't see that. They're quite obvious. They're not the round little donuts. And in fact, there's some historic records and archaeologic records that have found that sickle cell disease has been present for tens of thousands of years. And there's some evidence that maybe King Tut actually had sickle cell disease. So his skeleton was recently x-rayed. He was found to have characteristic bony findings that we see with sickle cell disease. And we know that there's carrier rates of up to 22% in Egyptian oases. Of course, as an autosomal recessive condition, consanguinity can play an important role, and it's well known that the Egyptian pharaohs practiced consanguinity. He also was found to have malaria in his, when they analyzed his mummy, malaria DNA was found. And so there's some thought that perhaps he didn't actually die of malaria, but that precipitated a fatal vaso-occlusive crisis related to his underlying sickle cell disease. So the story of the mosquito and malaria leading to this selective pressure and mutation in hemoglobin repeated itself several times throughout history. So there's actually 5 distinct sickle haplotypes that have been identified mainly in sub-Saharan Africa, but also in the Indian subcontinent as well. And of course, as a result of migration, forced often through the slave trades, these mutations made their way throughout the world. So just to get into a little bit more detail about the pathophysiology of sickle cell disease for those who are not familiar with it, like I said, it is a monogenic disorder, so a single point mutation in beta globin. So in the 6th codon, instead of having glutamic acid, you have valine. And what that does, it leads to this abnormal polymerization, distorting the red cell. So there's 3 pathophysiologic consequences of that. Number 1, these distorted red cells do not flow through the vasculature very well. So that's something called vaso-occlusion. Number 2, because of this stress within the red cell that leads to stress on the membrane, these cells prematurely hemolyze. So the average lifespan of a red blood cell is about 120 days. Sickle cell is about 10 to 15. So there's a state of chronic hemolysis in these patients. With chronic hemolysis, of course, free heme is toxic to our body, so we need scavenging systems to protect it. One of those major scavenging systems is nitric oxide. And so with chronic consumption of nitric oxide, this leads to a state of relative vasoconstriction within the vasculature. And we get a lot of vasculitis type phenomenon in the vascular beds. I often teach the residents, like, think of sickle cell disease as a chronic vascular condition. This leads to head to toe complications for patients. So there's acute complications and chronic complications. Some of the more common things that we see and more devastating ones are acute strokes. There can be chronic complications like silent infarcts, cognitive dysfunction, vasculopathy, going down to the level of the eyes. Patients can become blind from retinopathy. Patients can develop a fatal complication called acute chest syndrome, whereby you get sickling in the lungs that can lead to hypoxemic respiratory failure. They're at increased risk of having blood clots, increased risk of pulmonary hypertension. I could keep going through this list, but really the hallmark of the disease and where we often interface with these patients is at the point of the emergency room when they're presenting with a painful vaso-occlusive crisis. And so this diagram is all very well and good, but I think it's better to show you what a patient experience living with this is like. So this is one of my patients. He's got homozygous S. He lives in a community 2 hours outside of Vancouver. He is on hydroxyurea, which is kind of the gold standard treatment for patients with sickle cell disease that we'll talk about. He self-supplements with over-the-counter L-glutamine, which is an amino acid we'll talk about, and has previously tried a medication called crizanlizumab and has had red cell exchanges over the years. He's currently, in addition to his hydroxyurea, on a clinical trial with a pyruvate kinase R activator called etavopivat. And I asked him just to tell me a bit about his experience interfacing with the healthcare system. Keep in mind, he is a doctor himself, so he sees it from the other side. And this is what he said about his experience living with pain as a patient with sickle cell disease. So although I often have less pain, I live with chronic pain daily. I only very reluctantly go to the ER. The ER doctors believe I'm addicted or dependent on opioids. I've been offered anticoagulants instead of opioids to treat my pain. My practice was forced to change because I can no longer practice hospital-based medicine. He had another complication of his sickle cell disease, avascular necrosis, and so he needed a hip replacement. And just talking about the painful recovery process from that, taking months to recover. He also unfortunately suffers from ulcers. So he says, I've had ulcers on and off since I was 17. Each ulcer takes 3 to 12 months to heal, and I'm mostly homebound during this phase. He's got young children, so he says, I feel like a burden to my young family. It takes 3 hours each debridement and dressing, which I do myself. If I weren't a doctor, I have no doubt I'd be on disability. I've spent thousands of dollars in dressings and equipment for my ulcers. And this is just some of his other complications that he experiences that he shared with us. So another common complication is priapism. And he says, I learned to self-aspirate when I have priapism because I don't want to go to the ER because he said such horrific experiences previously. Sometimes it feels like I'm playing a game of whack-a-mole with all my complications. Feelings of fatigue and depression are constant. Fertility is another known complication. So my son was conceived with IVF due to my fertility problems. So that's just a snapshot of one patient living with this disease. Let's take a look at the burden of disease globally. So the estimated prevalence is around 8 million people and about 5 times as many people living with trait. It's projected by 2050, around 400,000 infants will be born with sickle cell disease globally. And 90% of them live in 3 developing countries. So Nigeria, India, and the DRC. Most children will unfortunately die before they're 5 years of age, and often not even knowing that they have the disease. It's highly stigmatized around the world, so people are often identified by the presence of scleral icterus. They're often shunned by their families and communities. I've had patients coming from Africa that when they were, I don't know if any of you have ever seen anyone experiencing a pain crisis, but people are often writhing in pain in the emergency department. I've had people tell me that when they were kids growing up in their culture, it was thought that they had demons. They were not treated. It was just, if there was something wrong with them, they were shunned. Access to diagnosis and treatment in many parts of the world is extremely limited. Here in Canada, unfortunately, we don't yet have a national database. That's something that we're working on. But we think there's about 8,000 people living with this disease. And traditionally, it's been focused in the East. They've got large Afro-Caribbean populations in places like Toronto and Montreal. But the prevalence in Western Canada is rapidly increasing. And that's in part because of a lot of African immigration. So about 13% of people coming to Canada now are coming from an African country. So it is now the most common rare disease in Canada and rapidly growing. And historically, there's been a lot of funding disparities because this affects people of predominantly African ancestry. So compared to diseases like cystic fibrosis, which affects people of Caucasian ancestry, there has not been as much interest in the disease and funding for research and treatment. So this is just to highlight the growth that we've seen in our program. So I joined the program in 2017. We had around 50 sickle cell patients. We've now got 160. So we've had rapid growth over the last few years. And these are patients that are coming from entirely different health systems, where adapting to care in Canada is very different. They've often never been on treatment. So there's a lot of education and effort that goes into, 160 doesn't seem like a lot, but the amount of effort to educate these patients and get them started on a treatment and get them to buy into a treatment paradigm is really a lot, and it takes a team in order to be able to do that. We also have patients newly in the Yukon. So as of a few months ago, there's 2 patients living with sickle cell disease in the Yukon, which historically have not been there before. So that introduces a whole new set of challenges in terms of resources in a place that has never even had patients like this before. And keeping in mind, it's just a tiny little percentage of the 8 million people around the globe. So life expectancy in sickle cell is improving, and there's been a few key interventions. So this is coming from the US. And the first is, so in the 70s in the US, they introduced a Sickle Cell Control Act, whereby they identified carriers. That was in order to educate them about the risk of having a child and eventually develop newborn screening programs so that children were picked up early on in the course of their sickle cell disease. The next big intervention was the use of preventative penicillin. So with sickle cell disease, there's chronic vaso-occlusion of the spleen. Patients become functionally asplenic and are at risk for sepsis with encapsulated organisms. So with the use of preventive penicillin starting very early, like 2 months of age, they found an 85% reduction in the risk of strep pneumosepsis and deaths in the patient population. So that's become standard of care for pediatric patients. The next big intervention was the use of hydroxyurea, which was established in the mid-90s in a randomized controlled trial. This is on a timer. That was found to reduce the number of vaso-occlusive crises, hospitalizations, and numbers of acute chest syndromes as well. So really standard of care. And with subsequent follow-up data, we know that it has a mortality benefit as well. And finally, the last big intervention was transfusion for stroke prevention. So the natural history of untreated sickle cell disease is around 11% of children will have a stroke by the age of 18 if they are not identified and started on a transfusion regimen. With chronic transfusion therapy, there's a 95% risk reduction in stroke. So again, a huge step forward. So current estimates of life expectancy with sickle cell disease, when we look at cohort data and simulation modeling, it's around 54 years. When you adjust for quality of life, though, you can take off 2 decades because of all the morbidity associated with this disease. And these are very expensive patients to care for and very resource-intensive patients to care for. The direct medical costs are estimated to be around $2 million over the course of a lifetime. And just delving into quality of life a little bit further, on the top, you can see green. So that represents pediatric patients. And you can see that even as children, the quality of life associated with sickle cell disease is similar to having a malignancy and being on chemotherapy. When you switch to the bottom part in yellow, when they're adults and they've accrued more comorbidities, it's actually worse than being on chemotherapy. And these are patient-reported outcomes. So how do we care for these patients? I mentioned they're very resource intensive. Well, it takes a village, and I'm very grateful for all the people at this hospital who really help us support these patients. So in our clinic, we're doing assessments every 3 to 6 months with interval drug and blood work monitoring. Many of our patients are on chronic transfusion therapy. I mentioned in peds, they get annual transcranial Dopplers to screen for their cerebral vascular velocities, which can predict stroke. Our adult patients are getting regular MRIs and MR angiograms of their brains to screen for vasculopathy and silent infarcts. They need to see ophthalmology every year to screen for retinopathy. Some types of sickle cell disease are associated with sensory neural hearing loss, so they need to have audiograms performed. Pulmonary hypertension is a known risk, so they're getting echocardiograms, ECGs. They're followed by most of them are followed by cardiology. Many of them get restrictive lung disease, and there's a high association with asthma. So many of them are followed by respirology as well. Sleep apnea is another common comorbidity in this patient population. They get gallstones. Many of them require cholecystectomies. So our general surgeons are getting more and more acquainted with them. A huge, especially as people get older, huge increased risk of developing hypertensive disorders and chronic kidney disease. We have one patient who had sickle nephropathy and has now had a renal transplant at the age of 28. We have specialized MRIs that we only offer at this hospital in BC Children's, where we can follow them for iron overload. Their increased risk of osteoporosis, so they get regular bone scans. Avascular necrosis of the hips and shoulders are common. So many of our patients have had hips and shoulder replacements, and so becoming increasingly well known to Dr. Pike and Dr. Umran. Inpatients, many of them do require transfusions if they have a complicated vaso-occlusive crisis. They're well known to the pain service. We often try and start these patients on PCAs. Their preoperative care, as you can imagine, is quite complex. Many of them have multiple emergency visits and hospitalizations. I think we have 2 in the emergency department right now as we speak. We'll have to go see them after. And often they require ICU and HAU resources as well, if they've got a severe chest crisis or multi-organ failure. We are a provincial program in nature, and not all of our patients live in Vancouver. I mentioned we have patients living in the Yukon. We have patients living in every health authority. And so often, because there's not the specialized care available, we have to transport them here. And of course, there's a cost associated with that. As you can imagine, pregnancies are complicated for mom and for babies. So there's a lot of resources going into helping support these pregnancies with very successful outcomes. And we really require specialized blood products for these patients. Many of them are alloimmunized, have antibodies, and also, and what I always teach the residents is everyone, when we're thinking about providing blood products, we always think about ABO. Everyone forgets that there's actually dozens of other red cell antigens, many of which are racially determined. So finding blood for these patients, and it's recommended that we match on minor antigens as well to decrease the risk of alloimmunization. And so finding blood products for these patients is very challenging. CBS has a rare blood program that we're often utilizing, and sometimes there's not enough blood in the country to support these patients. So shifting a little bit to pharmacotherapies in sickle cell disease. So the first description of this in the Western medical canon was in 1910, when a medical student from the West Indies was studying in Chicago and presented with a vaso-occlusive crisis, and they observed sickle cells. And it was actually the first molecularly defined disease in 1914. Linus Pauling actually identified hemoglobin S. So despite that, it took 50 years for the first drug to be approved, which was hydroxyurea, like I mentioned. And then it's only more recently that we've had more drugs approved that I'll go through. So this is our current therapeutic landscape. So of our 160 or so patients, we've got about 12 patients who are chronically on red cell exchange. That's the therapy only offered at VGH. We don't do it here, so they have to go over there. As I mentioned, there can be issues with blood availability, and sometimes we just don't have enough blood to optimally exchange them. Hydroxyurea, as I mentioned, is really the gold standard of care. And the main mechanism of hydroxyurea is to induce fetal hemoglobin, which interferes with sickle hemoglobin. So there's less sickling, and that's why patients in the RCT were found to have fewer vaso-occlusive crises and chest syndromes. It's also quite pleiotropic, so it has we also use it as a cytoreductive agent. And in sickle cell disease, we know that reducing platelets and white cells can often help with vaso-occlusion as well. And it's actually a nitric oxide donor, so it can help with the vasculopathy that we commonly see. L-glutamine is, of course, an amino acid. It's marketed in the US as Indari, which is pharmaceutical grade, and has been shown in clinical studies to decrease hemolysis in patients. It was FDA approved, and a lot of these drugs are FDA approved with kind of borderline evidence, just because there's not a lot of other treatments out there. But it was FDA approved in 2018. They have not sought any approval in Canada. There's no compassionate access program. So if patients, even if we wanted to do like a special import access, patients would have to pay $25,000 per year to be on an amino acid, which is completely ludicrous. Even in the US, there's not been a lot of uptake because insurance companies haven't really been funding it. Crizanlizumab is another medication. So it is a monoclonal antibody targeted against P-selectin. So P-selectin is on the surface of platelets and endothelial cells. And in a phase 2 RCT performed in the US, it was found to decrease vaso-occlusive events, lengthen the interval between VOCs, decrease hospitalizations. Unfortunately, when they went to a phase 3 multinational trial, that same effect was not seen. So as a result, they're not going to be applying for Health Canada approval. We had been accessing it through a special program and did have some patients on it, but they've told us that no new patients are allowed to enroll as a result of this. Again, if patients wanted to pay for this, it's like almost $90,000 per year, so not affordable. And then finally, there's voxelotor. So voxelotor actually works to stabilize hemoglobin S in the non-polymerized state. So definitely there's been lab data to show that it increases hemoglobin, decreases hemolytic parameters. We're still not quite sure if it's going to improve clinical parameters like VOCs and hospitalizations. It has recently become available in Canada, so there's an access program through Pfizer, which is good because otherwise it's also very expensive. So that's what's out there right now. We do have some clinical trials ongoing as well at our site. So using a pyruvate kinase activator that has been shown to decrease hemolysis. And then we're going to be embarking on a trial with essentially an amino acid that again has been shown to improve hemolysis. But essentially there's no Health Canada approved therapies for sickle cell. So in order to understand curative therapies, we first have to kind of understand the role of fetal hemoglobin. So as I mentioned, presence of fetal hemoglobin decreases hemoglobin S polymerization. It actually also improves the rheology of the red cells and how they flow through the vasculature. And we know this because hereditary persistence of fetal hemoglobin is commonly co-inherited as a protective mechanism in patients with sickle cell disease. So there are populations who will have, so you and I, without HPFH, should have fetal hemoglobin levels of less than 1%. But there are people who have levels of 15, 20%. And we know that they have a very different clinical phenotype, a much milder phenotype of their sickle cell disease. We also know that because fetal hemoglobin production doesn't shut off until about 6 months of age, that there's an initial 6 months of protection or so in neonates. And so this is, of course, is what hydroxyurea is exploiting, but this is really where cellular therapies are headed as well. So this is very topical. It is all over the popular press. So this is from the New York Times recently, the cover of the New York Times. So this is a young woman, 16 years old, who was the first recipient of a CRISPR gene editing therapy for sickle cell disease. Before we talk about gene therapy, though, it's important to remember that transplant is still a very effective curative therapy. So matched sibling donor transplant is really standard of care now for patients with severe disease. We know that the optimal age for transplant is less than 14 years of age. That poses a lot of ethical challenges because often you're taking a prepubertal child who really can't say much about what they want their reproductive capacity to be like, what they want their life to be like, and offering them a therapy that is usually associated with a loss of fertility. And that can be challenging in cultures as well, where fertility is very important to the patients and their families. We also know that only 15% of patients will have a matched sibling donor, so the vast majority do not. There are other forms of transplants, so haploidentical transplants like from a mother or a father, but these are still considered experimental and the outcomes are not as good as they are for matched sibs. These still require myeloablative chemotherapy, so that's like a month in hospital recovering from the toxic effects of chemotherapy. And there's risk associated with it. So there's, even though outcomes for like matched sibling donors are like, 95% disease-free survival, there still are risks, mortality, while you're going through the process of myeloablation, serious life-threatening infections can occur. Patients can develop graft versus host disease. The graft can fail or it can be rejected. So this is where, because of only a minority of patients will have a sibling donor, this is really where the interest in gene therapy came from. So what if we circumvented needing a donor and using the patient's own stem cells? So there are 3 different ways that are kind of commonly being used to go about this. So you would think with a monogenic disorder, the simplest way would be to actually just correct that beta globin defect. But technically, that's actually a lot more problematic. So the 2 approaches that I'm going to discuss in more detail have taken alternative perspectives. So the first is gene addition, whereby often with a viral vector, you are introducing a new non-sickling hemoglobin into stem cells and then allowing it to develop. And then the second is using gene editing. And so often this is targeting genes that control fetal hemoglobin. So by turning off suppressors of fetal hemoglobin, we can allow high levels of fetal hemoglobin production. You can think of it as kind of like supercharged hydroxyurea. So there are all sorts of clinical trials ongoing right now looking at these therapies, but they all really have the same backbone as you deliver myeloablative chemotherapy and then a cellular therapy product. And rather than truly being curative, you can think of them more as one-shot, highly effective disease-modifying therapies. So the first one I'm going to talk about, you don't even want to try and say this name, so lovo-cel for short. It's a product marketed by Bluebird Bio. So what happens is patients have their stem cells collected. Those are taken and manipulated ex vivo. In this particular product, it's a lentiviral, so an HIV type virus that injects this novel hemoglobin that they've created that does not sickle. The patient then receives myeloablative chemotherapy, the stem cell product is infused, and we wait for it to engraft. So there's been multiple trials looking at this. So they've done it in children as young as 12 and as adults as old as 50. Patients with severe sickle cell genotypes, and they had to have clinically defined severe sickle cell disease with hydroxyurea failure or intolerance. And the severity criteria that they defined was 2 or more vaso-occlusive crises within the past 2 years, 2 or more acute chest syndromes, history of overt stroke, or having elevated TRGV suggestive of pulmonary hypertension. And so the initial cohort of these patients, they started doing this, it was 2008. And so this was really the first iteration of these therapies. And so there was a lot of stuff to be learned. But in group A, the first group, they actually did bone marrow harvests as their source of stem cells. They did lower intensity conditioning, and they did lower cellular target. So they were targeting lower stem cell doses. As I'll talk about, there were some poor outcomes with that initial cohort. So they have then evolved their process over the years to now we can actually collect peripheral stem cells. One of the barriers to that historically has been the usual agent we use is filgrastim or GCSF. That has a black box warning in sickle cell disease because it can cause neutrophil degranulation that can lead to acute chest and vaso-occlusive crisis. So we needed an alternative mobilization agent. So with the advent of plerixafor, patients were able to be peripherally collected with that. And eventually the treatment evolved to have higher, more intensive myeloablative conditioning and more stem cells as well. So this is the data that was most recently presented at our big annual meeting, the American Society of Hematology in December. So it was up to and including 47 patients with a median follow-up time of around 35 months. They have found that the average time to engraftment is 35 days. And so practically what that means is that 35 days of a patient needing to be admitted to a BMT ward, recovering and protected from fatal infections and closely monitored. They found that the peripheral blood vector copy of this novel hemoglobin that they had transduced was stable throughout follow-up, and that the levels of this new hemoglobin, which they can distinctly measure aside from other hemoglobins, were up at least 45 grams per liter. And as a result, total hemoglobins were increasing from 87 on average at baseline to 118. And most importantly, 90% of patients had a complete resolution of their vaso-occlusive crises. And 97 had a complete resolution of severe vaso-occlusive crises where they would have to go to hospital. So that 90%, they might have had a few pain crises that they could manage at home, but 97% were no longer going to hospital. And not surprisingly, when you don't have sickle cell disease anymore, your quality of life improves. So in the patient-reported quality of life outcomes, those are significantly better at 48 months. Now, I mentioned that first patient group where they used the lower level conditioning, where they used the stem cells from the bone marrow, and they used a lower dose of stem cells, those patients were problematic. And they actually, there were 2 cases of acute myeloid leukemia in that cohort. I think it was only like 7 or 9 in that cohort. So it was a pretty high percentage. And they happened pretty quickly. So one was at 3 years after treatment and one was at 5.5 years. So there was some question, was this insertional oncogenesis? Did the therapy go off target and insert into an oncogene? We didn't see that in the first case. In the second case, it did seem to insert into an off-target gene, but not something that was felt to be an oncogene. One of the hypotheses is that having that lower stem cell dose and not enough conditioning really led to the situation of stress erythropoiesis, so trying to reform your red blood cells. And that may have allowed for clones of pre-malignant cells to survival benefit. That's not been definitively proved, but we really have not seen that subsequently once tweaks have been made to how we've been dosing this. So where are we at with this therapy in terms of market access? So because this therapy increases, because it gives you a functional hemoglobin, it's also being marketed in thalassemia. And so they tried to market it in the EU as a thalassemia product. And it was actually approved by the EMA back in 2019. But then the price negotiations completely fell apart. So they were trying to, market this at around $2 to $3 million per patient. The payer said no. So they subsequently withdrew it from the market. It's now been FDA approved. They're trying to exclusively market it in the US. Very doubtful that they will be coming to Canada with our regulatory and payer requirements. So the next treatment, Exocel or Casgevy, this is a product marketed by Vertex Pharmaceuticals. And so this is taking the gene silencing approach. And the gene that they are targeting, excuse me, sorry, I'm just getting over a cold. The gene that they are targeting is BCL11, which is a repressor of fetal hemoglobin. So the idea is that if you can silence BCL11, you will get increased levels of fetal hemoglobin production. And so it's a similar treatment paradigm to lovo-cel, like I showed you. So patients have stem cells collected. They are manipulated ex vivo. In this case, the way we get the therapy in is we use electroporation, and it's actually CRISPR-Cas9 platform that is editing the BCL11 gene. That product is then reinfused to a patient following a period of myeloablative chemotherapy, and then we wait for it to engraft. And so their inclusion criteria was much simpler. They, again, had sickle cell severe genotypes, but you just needed to have 2 or more severe vaso-occlusive crises within the last 10 years and no matched sibling donor. Now, this is a more challenging therapy to deliver, just because you have to collect a lot of stem cells for these patients. And on average, patients needed 2 cycles of mobilization to collect that. I mean, usually if we're collecting a transplant for like myeloma or, leukemia, it's like 1 cycle. But these patients, some of them needed up to 6 cycles. So very resource intensive from an apheresis stem cell collection point, because they targeted such a high dose. They saw similar engraftment times compared to lovo-cel, so it was around 35 days as well. And again, that's the time that patients need to be in an inpatient bone marrow transplant unit, protected from the risk of infections and recovering. And so their primary endpoint that they looked at was something that they called VF12, so freedom from vaso-occlusive crises at 12 months. And you can see here 96.7% of patients met that. On average, these were patients who were having, 2, sometimes up to 9 or 10 vaso-occlusive crises a year leading up to that. And so the secondary endpoint was how long they had been free, and the mean was 22.4 months, keeping in mind, we've only got about 3 years of follow-up in these patients. So this does seem to be relatively durable. As you can see here, as intended, we did increase total hemoglobin from baseline so the baseline's on the bottom there and then up on the top. And it didn't really seem to differ between adolescents and adults. And most importantly, what was found is that these patients, it really was effective at increasing fetal hemoglobin. So on average, patients in this trial had a fetal hemoglobin percentage of 44%. We know that about 20% of fetal hemoglobin is very protective in modifying the phenotype of sickle cell disease, so they're getting twice that amount. And again, no difference between adults and adolescents. Another kind of key component of fetal hemoglobin is it also depends on how it's distributed in the red cells. So not all red cells will contain fetal hemoglobin, but if they do, that is more protective than if it's a little bit patchy. And this seems to have a pancellular distribution of fetal hemoglobin, again, adding to the protective effect. Over time, the presence of this gene therapy product in both the blood and bone marrow was stable and does not seem to be declining as time goes out. And for both of these therapies, most of the side effects that we're seeing really are related to myeloablative chemotherapy. So things like nausea, stomatitis, vomiting, infections, none of the side effects really have been attributable to the cellular therapy product itself. Thus far in this product, we have not seen any malignancies. And so there's a lot of unanswered questions. I mean, this is like science fiction that we're living in now. So, what are the long-term side effects of these therapies? Most of them we've only had, 3 to 6 years of follow-up. The FDA has mandated that patients need to be followed for 15 years. We actually had some patients treated with the exa-cel product for thalassemia at BC Children's. They've now been enrolled into a long-term study at our institution, and we're following them for that 15-year period. Will it continue to be durable? So far, it does seem to be, but again, our follow-up period is short. how are patients going to afford therapies that are going to be marketed around $2 to $3 million? How are health systems going to afford this? How does that determine access in a therapy that's so expensive but life transforming? Because of the use of myeloablative chemotherapy, most of these patients are becoming infertile. So as part of the studies, fertility preservation is included in the study, but as these are commercialized, how are patients going to do that? I mean, fortunately, we're going to have a cycle of IVF coming in BC in the near future, but excuse me, the cost of preservation of oocytes or embryos or sperm, who's going to pay for that? Where we are looking in future is to hopefully develop an in vivo gene therapy where you can bypass the need for chemotherapy and just deliver an infusion. We're still quite a ways away from that, but there's a lot of investigation into that. And of course, offering a less toxic conditioning regimen where patients don't need to be admitted to hospital for, over a month. And then really, how are we going to have therapies that are less toxic, easy to deliver so that we can deliver them to the parts of the world that really need them? And so just to touch on how we have been adapting to the increased prevalence of sickle cell disease in BC. So we have been fortunate to have, thank you, Sandy, a funding bump from PHSA where up until a year ago, it was just myself and a nurse trying to manage all these patients, plus our thalassemia patients, plus everything else. So we've been fortunate to expand our team. So we now have a social worker, we have a pharmacist, we have a psychologist, we have physiotherapists, and we have a clinical coordinator. That's been really great to really improve the quality of care that we're delivering to these patients. We're also trying to grow our clinical trial expertise, so trying to find newer therapies to deliver to these patients. We have a lot of quality improvement projects on the go. So two of them will be highlighted in the QI day in the next month. So hopefully you'll come check that out on June 20th. And then a really big thing that we've been trying to do is improve transition from the pediatric hospitals. So we've been fortunate to partner with the Scotiabank transition program, and they've spent some time in our clinics and really trying to improve that process for our patients. And really, I mean, there's so many people in this hospital that help support our patients. So I just want to take a moment to thank everyone for all the great work that they help us do with admittedly very challenging patients at times. And with that, I am happy to take any questions.
Try some just live it happy life there at the end. That is the piece called niche.
I have a question on newborns. So as we know that the clinical complications are usually few months after they're born, but do we know much about the molecular data types like genes and proteins that start changing early on that gives us insight as to what to, like preventative measures based on that ideas? Has there been anything like that?
Yeah, I mean, we know that usually in terms of protein switches, the fetal hemoglobin switch usually occurs at around 6 months of age. But even before that, the disease still does seem to be active, and kids are at risk of things like infections before that. So it's actually recommended that we start prophylactic penicillin as early as 2 months of age when there still might be some protective effects from fetal hemoglobin. We're fortunate in BC that we have newborn screening as of a few years ago. So all patients with disease should be picked up right from birth so that they can be connected to the pediatric program, started on things like penicillin. Parents are taught to palpate spleens in case the baby has a splenic sequestration crisis, so they need to know about. And of course, we can start hydroxyurea as early as 9 months of age. And that's really becoming standard of care for at least kids growing up in the developed world, is early onset of hydroxyurea. I have some patients who've grown up like that and have never had a pain crisis. It's only when I take them off when they're thinking about becoming pregnant that they're like, what's happening to me? You know, unfortunately, a lot of our growth is actually from patients coming from parts of the world where they've never had access to early treatment. So by the time they arrive with us, there's a lot of morbidity already associated with the disease.
And just to follow up, like, do we like consider like sickle cell trait as something we should also consider? Because recently, like with COVID-19, there were studies that the vaccines work differently, or they have some kidney comorbidities.
Yeah, so I mean, we've always kind of dismissed trait. One of the things I would love to do, Sandy, is start a trait clinic, because we know that there are certain things that patients with trait experience. So there is, for example, increased risk of chronic kidney disease, increased risk of a certain type of renal cancer. They're at increased risk of blindness if they have injury to their eyes, increased risk of VTE. They can actually have a vaso-occlusive crisis under the right conditions.
Yeah.
So there is some, and of course, then there's the reproductive counseling that needs to go into seeing these patients. So trait is still, just because of the burden of disease, trait has always kind of been historically a little bit dismissed, but we do know that there are special needs for these patients, and hopefully we can start to better address those in future.
Thank you.
Yeah, I think we're both.
If there's any questions online, there's none more in the room. Okay. Well, thank you for your attention. If anyone ever wants to come check out our clinic, spend time with us. We have a lot of learners. We're always happy to have people spend time with us.